Assalamu alaikum. Today, inshallah, we will talk about the basics of flexible flat foot. Actually, there is no exact definition for flat foot. But if you remember in the lecture of Genovarum, I inform you that there is a development starting from since birth. The newborn born with maximum varus, then become rectus at 2 years, then maximum valgus at 4 years, then gradually decrease to the normal valgus of adult, about 7 years. The same for the child regarding flat foot. The child born without arch till maybe up to 4 years. So all child apparently have flat foot till about 4 years and gradually develop maybe till 10 years. So don't hurry to judge about flat foot only from cosmetic point of view. Okay. Second thing about types of flat foot. Flat foot either flexible or rigid. Flexible flat foot and rigid flat foot both in children and in adults. Flat foot in children starting with hypermobile flat foot just due to ligamentous laxity, and ligamentous laxity with tight Achilles tendon, or rigid flat foot, some of its bone unite together in some way. So it is called tarsal coalition. And in between there is a gray zone called the accessory navicular. In adult, the most common cause of acquired flat foot starting flexible then going into rigid is tibialis posterior insufficiency. So our rule is to detect our child is in which stage or in which what is the cause, which type he have, because totally management is different. Hyper flexible flat foot is the majority of cases, so you wouldn't do anything for a child for majority of cases. Regarding pathoanatomy for us mainly to detect how to manage. If you detect the deformity, site of deformity, and you need to do something for the child, you have to know the site of the deformity to act on. And also for the reverse imbis cavus. So if you know the sequence here, you will predict it in the bis cavus. So I want you to know this picture. This is the navicular, and this is the calcaneus. Here is the head of the talus. Should be the head of the talus with the talus. In flat foot, and this is called the acetabulum. Acetabulum of the talus, of the ankle and foot. In flat foot, the head of the talus shifted medially and dropped down. So the head of the talus shifted medially. So the line or axis line of the talus become far away from the axis of the calcaneus. And the big toe, first metatarsal, is elevated up. So if I inform you what is the pathoanatomy of the bis cavus, you will say the reverse. Also, if the head of the talus going or shifted, dropped medially and inferiorly, the calcaneus will valgus. So if I want to manage this, I will have to shift the calcaneus medially. For example, if you know that the first metatarsal is elevated, so I want it to make a dorsiflexion osteotomy, to make it dropped, and so on. This is only for examples. Regarding clinical picture, all child will come to you mostly asymptomatic. Only the parents want you to assure them. Regarding ankle and foot examination, we take a detailed lecture about ankle and foot examination, and we do our own system. You can do your own system, whatever, but be systemic and don't forget any item. For us, we starting by gait. So when you go for gait, if he is, for example, adolescent, who can obey your command, you can inform him when he go to the walking and go to the wall, in front of the wall, please do tiptoe. The calcaneus should, when elevated from the foot, from the floor, going into varus, and when it's go back to the floor, go into valgus, like Mercedes. So to increase wide bed of support, when he on the floor, he will go into valgus. Then to make a rigid column, the subtalar going into the varus through the calcaneus. So this is a flexible flat foot, not a rigid one. If it is fixed all the time into varus from standing position in tiptoe and the calcaneus on the floor, still in varus, so it is fixed deformity. If he if the child is can't obey the command, you can do jack test, dorsiflexion of the big toe will reconstitute normally the arch of the foot, and the calcaneus will go into varus, and the reverse. So it is flexible, not rigid. The last one is examination of the Achilles tendon. You want to differentiate between flexibility and rigidity, and you starting with step 2, then or jack test, and going into finally into Achilles tendon examination to detect the second type. If you remember in the types, first one is hyperlaxity only, and second one is hyperlaxity with tight Achilles tendon. Through what is called silver scale test. Silver scale test, You can do it either prone, supine, at the edge of the table, whatever you want, but the same system for us is in prone position. Anyway, starting from extension or flexion, you can do the test. The aim of this test is to detect if the Achilles tendon is tight or not compared to the other side, and if it is tight below or above the knee. So if you're starting from extension and you do a dorsiflexion of the foot and it's reach, for example, neutral, and the other foot, which is normal, about 10-degree dorsiflexion, and you flex the knee, the same neutral position doesn't change. So the whole complex, which is gastrocnemius above the knee and soleus below the knee, is tight. So I will release here tendon Achilles. All the complex is tight. But if I flex and the dorsiflexion increased from neutral about 5 degree, then the only problem is in gastrocnemius. So I will do a recession here, higher above. Okay, if you do the same test starting from flexion, for example, and you do dorsiflexion of the foot and it reach also, for example, neutral in comparison to 10 degrees on the other side, dorsiflexion, then you extend the knee and the position of the foot is the same. So the whole complex is in the same position of tightness. So you will release here in the tendon Achilles. But if you extend and the neutral position of the foot become about 5-degree plantar flexion, so the tightness increase. So when you bring the gastrocnemius into function, it increase the tightness. So the tightness is from here, not from there. It is from above the knee, so you will do the recession here at the musculotendinous junction, not in and the fascia on the musculotendinous junction, not in the tendon itself below. So the key examination point is step 2, and jack test and Achilles tendon. Regarding radiograph, most of the children you wouldn't do any type of X-ray. Anyway, if there is indication that for example, most common example is very painful foot for adolescent, 10 to 12 year, for example. And when you did the exam, it is rigid. Subtalar doesn't move either with your hand or with the test. So you will do X-ray mainly to exclude tarsal coalition, the rigid one. Regarding imaging, X-ray, actually you have to know the angles for the sake of exam. Talocalcaneal angle, I inform you that the head of the talus drop medially and down. So this angle between the calcaneus and talus open. You take this line mid-axis by dividing, take a horizontal line here, for example, and bisecting it, then another line proximally and bisecting it, and both of midline you will be joining, and this is the mid-axis point, more accurate. And also for the calcaneus, either the same anatomical midpoints of first transverse line, midpoints of the second transverse line, then anatomical line, or just from the lateral surface of the calcaneus. This is called kite angle or AB talocalcaneal angle, because there is a lateral talocalcaneal angle here. Lateral talocalcaneal angle also bisecting the talus, and either from the inferior surface of the calcaneus or bisecting the calcaneus also. For example, anterior process, drop a line, then midpoint, drop a line, and then midpoint, and joining both points. Okay. Regarding talonavicular angle in the AB, so we have 2 angles in the AB and 3 angles in the lateral X-ray. AB talonavicular and talocalcaneal and talonavicular. Talocalcaneal and talonavicular. What's talocalcaneal? This means how much of the talus is covered with the navicular. So it is dropped or shifted medially. So if you take um, a line between the articular edges of the navicular and the articular edges of the talus should be parallel. If it is translated medially and uncovered, it will be a line like this, so wouldn't be parallel. This is the second one. Then between the talus axis in the lateral X-ray there is 3 lines. The first one is between the talus and first metatarsal, should be in line, but because the head of the talus is dropped down, the angle is open, should be 0, open inferiorly. And second one is calcaneo talocalcaneal, the same one, lateral talocalcaneal of the AB. And the last one is calcaneal pitch, when the angle between the inferior surface of the calcaneus, the lowest point, anterior process and tuberosity, then the horizontal. If the angle increase cavus, if it is down or decrease is flat foot. Actually, all these X-ray is only for the sake, after exclusion of tarsal coalition, for the sake of completion only, and MCQ and written. Regarding treatment, we are treating now basically for hyper flexibility. Hyper flexibility, please don't touch the patient, the child. Then don't go for orthotic, no rule. Actually, per foot for the development is uh, well developed without shoes. Proprioception developed well without shoes. Per feet is better than shoes. So please don't prescribe orthotics in flexible flat foot, or actually in most of the flat foot except in adult. Stretching for Achilles tendon if silver sculled is positive. This is actually is sufficient for 99% of cases. Very rare, need something. If the tight Achilles tendon, you have to release. But with release, we can do something called arthroeresis. From the lateral side of the subtalar, you put a screw to block the valgus position of the calcaneus. There is a big two school, one with arthroeresis, not desis. Arthrodesis, no, arthroeresis. There is a big two school, one with and one against. One with, because it block the valgus movement, and about 1 year proprioception development, and the child gain benefit without major interference or without any interference. Actually, a very simple procedure. From the lateral side, you open about 2 centimeters, then wire under C-arm, then dilator, progressive dilator, and putting the maximum screw. Actually, it is extra-articular relation in the posterior facet, in the front of the posterior facet of the talocalcaneum. Okay, this is the first option. If the patient is needed, it's about without any cause, idiopathic flat foot, unresolved pain, no Achilles tendon tightness, you can do arthroeresis. Second option, you can lengthen the calcaneus. If you lengthen the calcaneus, you can stretch the plantar fascia and going into varus, going into cavus to decrease the flat foot. This is called calcaneal lengthening osteotomy. Other one, to cut, osteotomize the calcaneus and shifted it medially. It is in valgus, lateralized, so you will give it medially. Both options, this makes the Achilles tendon ball in varus except in valgus. So decrease the valgus pull of the Achilles tendon. And there is a combination of both through chevron osteotomy. You can doing a cut near the anterior process, then horizontal one, then another vertical one in front of Achilles tendon. This is the most important. And length and displace medially. Lengthen and displace medially. This is the general basics of flat foot, and we will go on for other types of flat foot and then Biscava. Thank you.